Hi, everybody. Welcome to our Ethics in Healthcare series, sponsored by the Community Memorial Health System. Thank you all so very much for coming out on this beautiful evening tonight. My name is Dr. Jim Hornstein. I am the chairman of the Bioethics Committee at the Community Memorial Health System, and I'm truly delighted to be moderating and participating in tonight's program. Now, I have a question to ask before we begin. Is there anybody here who has attended any of our other ethics and healthcare programs? Could you just... Yeah. I'm humbled and especially happy to welcome you back. Now, to our new guests, to those who are new to this program, let me tell you about what this Ethics in Healthcare series is all about. Under the guidance and support of Mr. Mike Ellenson, who is the Vice President of Development and Marketing, in addition to Mary McCormick, the Manager of Marketing, and the entire staff of individuals who are here, the Community Memorial Health System seeks to engage and educate the broader Ventura County community on topics which are both common but also controversial. We choose these subjects, believe it or not, about 6 to 8 months ago, not because we feel that these are easy subjects, but in fact because we feel they are quite important. And as times have evolved over the last 6 months, I'm sure you'll see that tonight's topic on physician-assisted suicide most certainly fits this bill. Now, it is widely quoted that Benjamin Franklin once said, "There are only two things in life that are certain, and they are death and taxes." Well, yesterday was April 15th, which of course was tax day, and today, April 16th, is of course It is not Death Day. Let's not be negative tonight. Tonight, however, is National Healthcare Decisions Day. So, to everyone here, happy National Healthcare Decisions Day. I can't think of a better place where I like to celebrate National Healthcare Decisions Day. But let me just take a minute before we begin and tell you why this day was created. And it was created very intentionally. And it was done to empower, to educate, and to inspire both the public and the healthcare profession to think seriously about patients' rights, about patients planning for their future, and what their future healthcare needs may mean to them, and what goals they have as they approach their future. Now, I can personally think of no other issue where patients' rights, patients' choices, and the future needs of patients truly explodes with such force and power as the issue of physicians helping patients intentionally end their own lives. Now, for us in California, this is no longer just a moral issue. And by that I mean we have had these conversations before where something could be right or wrong or good or bad, the morality of an issue. But now this has become a serious legislative and legal issue. And as you will hear through the course of tonight, just last week, April 7th, our own local state senator, Hannah-Beth Jackson, helped to pass out of the Senate Judiciary Committee a bill in the state of California that would allow patients with less than 6 months to live to receive a prescription for lethal drugs, which, if the patient then chooses, can end their life. This is happening today. Now, I can't tell if that's for what I just said or for the fact that I'm delivering it so well. I imagine. By the way, we invited Senator Hannah-Beth Jackson here. Is anybody from her staff here? No? Okay. next time. So the fundamental question with this bill pending in the legislature, I think we can now say, which is facing both our legislators and our doctors, and frankly, everybody in this room and in our community. And the question basically is, should California patients have the right to physician-assisted suicide, and should California doctors have a duty to help them? Before, for some of you, I guess the answer has already been asked and answered. And again, this is an area which obviously entertains a lot of personal investment and passion, and I think that's terrific. And as you'll see, I think we should use that passion and interest to really focus on what the issues are and ultimately to help improve the lives of patients who have devastating terminal illnesses in California. If we can leave with that, we have all been successful, regardless of how you feel on this issue. But before I introduce tonight's guests, I'd like to take a few minutes to define some of the terms that we will be using throughout the course of this conversation. I'm going to do that because, to be honest with you, as a bioethicist that have studied these terms for years, they are completely confusing. And you do have a handout in front of you, which I hope you will look at as we go further with our discussion. And after I go ahead and discuss the terms of our conversation, ladies and gentlemen, this is Tom Kiskin of the Star. Tom is able to walk anywhere he wants at any time. Tom is a good friend and a thoughtful, reflective reporter on issues of healthcare, and frankly, Tom, I'm delighted to have you here. All right, so we were talking about, first I'm going to define some terms, and then what I'm going to do is present the ethical arguments both in favor of physician-assisted suicide and those against it. So I'd actually like to start with something that happened on the way into this program tonight, where I knew this would be controversial. I thought I would at least get to the podium before I heard remarks. But in fact, somebody took issue with the title of our topic even before I got here, which is a preview of coming attractions as to how strongly people feel about this. So as you can see, the title is Death Ever the Best Treatment? A Conversation on the Pros and Cons of Physician-Assisted Suicide. Now, I particularly picked the word conversation and not debate, because in my mind, in a debate, somebody wins and somebody loses. However, in my hope for tonight, it's that all of us will win, and we will all win through an open and honest sharing of opinions, which our community can then help to focus with our collective compassion and our collective caring on improving the well-being of patients and families facing what, for a second, we should never lose sight of, is the truly tragic experience of living and dying with a terminal illness. So what I'd like to do is begin with a few definitions, which, as you'll see, I've even labeled confusing because they are. So first, I'd like to begin with the word euthanasia. Now, euthanasia is actually a Greek word, literally meaning a good death. And as you see, euth means good, and thanatos means death. So the question is, what's a good death? Now, historically, at least through Greek times and then through the Middle Ages, a good death, if somebody used the word euthanasia, they meant this. They meant it's a death free from pain and suffering, which frankly, everybody wants. Don't we all agree that's actually what we want, is a good death? However, the actual word euthanasia, interestingly, has not been found and is not found in the Hippocratic Oath, but rather was coined approximately 200 to 300 years later. But that's actually not my point. It wasn't until 1869 when the historian William Leckey used the word euthanasia to mean what we now typically believe it means, which is mercy killing. So this is how people in modern times think about the word euthanasia, which does no longer mean a good death or a simple death or a natural death free of pain and suffering, but actually takes on a different meaning. So even words over time can change. So that's the first word that I just wanted to give you some background of. The next definition is, as you'll see, murder. Murder is the intentional taking of another's life without a legal justification. Now, what's a legal justification? Those are things like war or self-defense, okay? So murder is the intentional taking of another's life. What does suicide mean? Suicide is the intentional taking of one's own life, okay? One's own life. Moving forward, active euthanasia. What this refers to is someone other than the patient intentionally ending the patient's life. So this isn't the patient doing something to cause their death, it's somebody else. And there are two types. The first is called voluntary euthanasia, which is the patient instructs somebody else to end their life. Currently, that's legal in several European countries, including the Netherlands and also in Belgium. It is not legal anywhere in the United States. And then there is involuntary euthanasia, which means someone other than the patient intentionally ending their life without the patient's consent. The patient doesn't say, do this. It is just done for whatever reason of those other people, physician, family member, otherwise, and that is actually illegal throughout the world. Okay? So it's important you at least start with that background. And now we get to the topic at hand, physician-assisted suicide. And what that means is a physician provides the means of death, and in this case, a lethal prescription. They write a prescription. But the patient must perform the act. And what that means is the patient must actively swallow the pills. Currently, physician-assisted suicide is legal in 5 states, and those states are Oregon, Washington, Montana, Vermont, and New Mexico. So here's where some people disagreed with my topic. Some people, and in fact some groups in the current debates, do not like the term physician-assisted suicide. They prefer several other ways to describe what we just talked about. You will hear words such as physician-assisted death or physician aid in dying, okay? And what that means for those individuals is physician-assisted suicide. Now, I happen to believe that one of the reasons they advocate for that is both those terms, meaning physician-assisted death and physician aid in dying, are more neutral and less emotional, and I actually think they're right, okay? I do think they're right. I'm still not going to use them, and the reason is because I do not like those phrases, and I'll tell you why. I think they are ambiguous, and I think they add to even more confusion. With regard to the first, physician-assisted death, that could mean any physician assisting death, which could both be physician-assisted suicide with a prescription, or it could be euthanasia. Physician-assisted death is confusing and ambiguous. The other, physician aid in dying, I also do not like, because anyone, myself included, who takes care of patients at the end of life, always wish to help a terminally ill patient and aid them in their process. So again, it's confusing as to what you mean. Somebody could practice hospice care who aids patients at the end of life, but that's very different than physician-assisted suicide. So while I understand and respect the argument to change the terms of the discussion, personally, I think they add nothing to help the confusion, in fact, make it more ambiguous to me. So for the terms of the discussion, unless one of my esteemed guests wishes to change the topic a little bit, we will be using physician-assisted suicide for the reasons I gave you. And then finally, the term which I think is the worst term in all of bioethics is passive euthanasia. This truly is a terrible term. Practically speaking, in the hospital, we never use it. But what it means is, with the patient's consent, you take no steps to prolong a patient's life. In other words, you allow natural death, but no active intent is there to end a person's life. Okay? It's an old term. It was used widely in the 1920s and 30s. And frankly, thank goodness, it's almost never used today because it's bad. And I hope to never hear it again. So far are we okay? Those are tough terms. I did write them down in your handouts so you have them and you can look at those as we go further. But what I'd like to briefly do now is mention the status of suicide in America, which I think is also somewhat confusing and contradictory. I'd like to make just 4 points. The first is this, and you may not know this, but suicide is legal in all 50 states. And I'm going to repeat that. Suicide is legal in all 50 states. And what does that mean? It means that a person breaks no law if they commit suicide anywhere in the United States. Okay? However, states and communities try very hard for a variety of reasons, both morally and medically, to try to prevent suicides. And of course, all of you have seen this with things like 24-hour hotlines. If you're feeling depressed, if you feel you can't go on, if you think it's time to end it, to call these 24-hour numbers. You've also seen things like guard fences on bridges. These are ways the state and communities try to prevent people from committing suicide. Also, traditional medical ethics states that it is a physician's ethical obligation to try to prevent suicides. Traditionally, physicians are against suicide. How do we do that in clinical practice? We do that every day with involuntary things like 5150 holds, which means that if somebody says there's suicide, certain individuals are mandated by the state to actually take those people and put them in a treatment facility for 72 hours to help to calm them down. We also do that with implied consent to treat a suicide in the emergency room. So you can see we're a little bit schizoid in the United States. On the one hand, it's legal. On the other hand, you have a number of people who actively fight against it. It's a little confusing, don't you think? Yeah. Finally, I want to say a few words about religion. If I had a thicker jacket, I would put it on now in case you don't like what I say. I simply want to make a couple of very quick statements. Firstly, many people put great weight and great importance on their religious teachings in helping to define their attitudes towards suicide and physician-assisted suicide. I want to give you just 2 quick examples. Number 1, the Catholic moral tradition opposes any form of suicide because it violates the natural law foundations of their faith. The Catholic Church does not allow suicides for any reason, including physician-assisted suicide. Secondly, the Jewish tradition also opposes suicide, but actually for quite a different reason. In Judaism, a person's body is not owned by themselves, but rather is the property of God. Let me give you an analogy. Just like going to a library and checking out a book, one can read the book, one can enjoy it, but you can't rip out the pages, you can't mark it up, let alone you can't destroy it or burn it, because ultimately it is not your property. And that's the Jewish view of suicide and physician-assisted suicide. It is not yours to give up, and so therefore it's forbidden. Now, it's certainly not wrong, perhaps in a different venue, to spend an entire program discussing religious views on end-of-life care. However, for tonight's discussion, our goal is to stick to more secular views of why one could support or oppose the practice of physician-assisted suicide. And with that as an introduction, let me just briefly go over what I think are the strongest arguments, there are others, of why someone would support physician-assisted suicide and why somebody would oppose it. And again, you have a handout and it should be on there. And the word should be close to this, okay? I will list 4 major reasons. First, to support physician-assisted suicide. So why is the person sitting next to you so in favor of it and will cheer every time I mention that it's a good thing to do? Well, let me give you 4 reasons why those people are cheering, and I think they're incredibly legitimate reasons. Number 1, respect for personal choices. Number 2, inadequate pain and symptom management. Number 3, a great, deep, and abiding compassion for the suffering. And number 4, to prevent unwanted medical treatment. And I'll go over each one for a minute. Number 1, respect for personal choices. The possibility of a disabling illness which makes people more dependent and more debilitated horrifies many people. Those who favor physician-assisted suicide support the right of patients who have a terminal illness to end their lives by exercising their free choice, their moral autonomy, and their self-determination. People who support this contend that patients should have control over their lives, including the time and manner of their death. Furthermore, they believe that a patient's body belongs only to the patient, and it should be the patient's choice, which should be free of interference from anybody else. And anybody else would include the state, doctors, family, their religion, other people's religions, or even societal beliefs. In other words, personal choice in dying is fundamentally based on free will, liberty, and individual rights. That is one of the strongest arguments in favor of physician-assisted suicide, in my opinion. Reason number 2, inadequate or unavailable end-of-life care. Now, this was probably a somewhat stronger argument about 10 or 20 years ago, before the wide acceptance of hospice and palliative care. However, hospice and palliative care are still underutilized and underfunded in many parts of our country. And even with excellent end-of-life care by hospice or palliative services, it does take a tremendous commitment from families and friends to care for a dying person at home. And sometimes some families simply can't or aren't able to do that on their own, and there's virtually no resources for them. That's the second reason. Reason number 3, compassion for the suffering. Supporters of physician-assisted suicide believe that it is inhumane to require terminally ill patients to endure a downhill course while waiting to die of a future complication. Some people believe that a quicker and controlled death shows more respect for life than a protracted one. I sometimes hear this feeling in the statement, which in fact I heard today in my office when somebody asked me what my feelings were, and I asked them what theirs was, which is a common trick when you don't want to give your answer. And what they said is, quote, "We are often more compassionate in America to our animals than we are to people." So that seems to resonate with some people here in the audience too, as it did with my patient. Other proponents point out that suffering is not only physical, but symptoms like death anxiety, social isolation, loneliness, the feeling of being a burden, the loss of bodily control, and the loss of personal dignity can cause tremendous mental, emotional, and even spiritual suffering. And it is their belief that no amount of pain medication or palliative care can adequately control these symptoms and feelings. And lastly, number 4, avoid unwanted medical treatments. Again, historically, this was a very, very legitimate and serious complaint. Worse than death itself for some patients, people feared overly aggressive and painful care despite the hopelessness of their symptoms at the end of life. And sadly, even today, 25 years after the Supreme Court ruled that patients can refuse any and all treatments at any time, only about 30% of us as Americans have filled out our advance directive or our pulse forms. And even today, literally in our hospital today, without advanced care planning discussions prior to coming to the hospital, there still does exist the real possibility of patients receiving treatment they never wanted because nobody knew what their end-of-life wishes were. And let me just share with you something that everybody in healthcare knows and that you should know, that the time to have these discussions on advanced care planning is not in the ambulance on the way to the emergency room, and it is certainly not when you get to the intensive care unit. You've waited a little too long if that's when you think it's time to start those conversations. Anyways, these are the 4 common reasons why someone could support physician-assisted suicide. On the other hand, let me give you 4 different reasons why somebody would be opposed to physician-assisted suicide, and they are protection of vulnerable people, improved palliative and hospice care, a fear of abuse or the slippery slope argument, and finally, the ethical integrity of the medical profession. Again, I'd like to look at each quickly but separately. The protection of vulnerable people. By this I mean, by and large, we in America and our culture puts a premium on being young, on youthfulness, and on self-sufficiency. We like people to do things for themselves and to be young, right? We do. And in fact, we reward skills and achievements for people who accomplish things. On the other hand, people who are sick, the elderly, the frail, the disabled are uniformly devalued in our culture, and especially when you think about it, those that are terminally ill and dying. Studies have shown that Americans, by and large, are miserably unprepared to deal with their own aging and their own dying, let alone the aging and dying of close family members and relatives. Related to this, many of the studies that looked both at Oregon and Washington as to why patients ask for physician-assisted suicide do not show uncontrolled pain or physical suffering. I want you to understand this. The reasons that we are now seeing over the last 10 to 12 years in Oregon that people ask and then use physician-assisted suicide is almost never because of physical suffering and pain, okay? On the other hand, what the studies do show overwhelmingly is that patients' greatest fear relate to being a burden to their families or to their friends, almost 70%. So the argument of protection of vulnerable people goes like this. What, in fact, is the message we as society are giving to our vulnerable, sick, and our dying? Yes, in fact, you are a burden. Your fears of being a burden are, in fact, correct. Perhaps you could consider or choose suicide. The bioethicist Dan Callahan at the Hastings Center in New York, one of the premier bioethics institutes in the country, has said that, quote, for many, a new so-called right to die would quickly transform into a newer duty to die. Reason number 2, improve palliative and hospice care. By the way, and we don't have time to get into this, but just for definition, palliative care means providing comfort care for patients with serious illness, okay? Hospice care is a very different kind of care, again, providing comfort care for people who have 6 months or less to live. Palliative care is a bigger subset. Hospice care is a part of good palliative care. Now, according to several studies, most terminally ill patients change their mind about suicide after receiving better palliative care or treatment for depression. In studies of patients who have cancer and who are also suicidal, most are suffering from clinical depression, and depression can and should be treated. In addition, most doctors and nurses who actually work in this field and treat patients in the end of life feel that physician-assisted suicide is not medically needed, nor is it routinely asked for. Good palliative and hospice care for them can take care of the overwhelming majority of people who ask for physician-assisted suicide and do it today in a more humane way, as the argument goes. Reason number 3, the slippery slope argument, or a fear of abuse of any laws that we create to legalize physician-assisted suicide. What that means is this: since all laws, including SB 128 in California, that seek to legalize physician-assisted suicide have strict limits on its use, and opponents fear that these restrictions will be ignored over time. Let me give you a couple of quick examples. SB 128 requires, number one, a patient must be over 18. Number two, must be competent to make free and voluntary decisions. Remember, that's a choice made by doctors to decide if that's a free or voluntary decision. I don't know of how many of you went to medical school or residency, but I can assure you, you had no classes as how to determine whether somebody's choice is free and voluntary. That doesn't exist. Number three, a patient must have a documented terminal illness with less than 6 months to live. And number four, must be able to take and swallow the pills by him or herself. That comes directly from SB 128, and frankly, it also comes from the statutes in Oregon and Washington. So here's the slippery slope argument, or the fear that no matter what we put into the bill, this will be ignored by people. The question goes, what if the patient, in fact, is suffering greatly, but is only 17 and a half and not 18? Is it fair to deny this new right just based upon their age? Number two, what if the patient has a chronic progressive illness, but is not terminally ill, such as Alzheimer's disease? Okay, Alzheimer's disease, you could live for 7, 8, 9 years. Okay, so they definitely have a chronic illness, but they're not terminally ill. Is it fair to deny their right to make a choice before it's too late? What if, in fact, the patient is very old, let's say in their hundreds, and they are very frail, but they are not terminally ill? But let's say they've lost their spouse and their friends, they're living alone, have little resources, and they decide suicide is right for them. According to SB 128, they are not eligible for it. But is that right? Is it right to restrict that kind of opportunity for an individual to exercise their own personal autonomy because they don't have a terminal illness, but they have a legitimate reason in their minds to kill themselves? And finally, what if a suicide is botched? What if you actually attempt it and it doesn't go well and the patient lives for a variety of reasons? A rapid metabolism, perhaps they vomit the drugs, or perhaps there wasn't enough medicine. Here's a question. Should we then resuscitate the patient in the ER to bring them back to where they were? Can you imagine? Or should we just finish off the job and do... I'm not asking you to answer that. I'm asking you to reflect upon that. So here's my point. Okay, we could be here all night if we... Here's my point. All these situations suggest that a physician-assisted suicide is based on a patient's right to die, then how can we defend any of these restrictions on any patient's rights to choose to die for whatever reason they have? If we say patient autonomy trumps everything, then how do we make these rules that we say you have to follow? And the people who make this slippery slope argument say that it does not make sense, and over time, all of these rules will be overrun. And finally, number four, the ethical integrity of the medical profession. This is my last point. Historically, the Hippocratic Oath for over 2,400 years has made doctors swear never to intentionally cause harm. In one recent study, approximately 20% of cancer patients said they would change their doctor if they found out that their doctor performed physician-assisted suicide on other patients. And they said they would change their doctor because they would have lost trust. They came to the doctor to be a healer and not to be a killer. 20% in that study said they would leave because the doctor has lost their ability to be professional. Now, reflecting this, the American Medical Association Code of Ethics continues to draw a clear line prohibiting doctors from intentionally causing the death of their patients for any reason, including the reason that the patient wants them to. In fact, virtually every doctor organization believes that a physician's ethical responsibility is to promote health, to be a healer, protect the sanctity of life, create a long-standing relationship with a patient throughout the entire course of their life and their natural death. Most doctor organizations do not wish doctors to be instruments of death, and they do not consider the termination of life as an improved health outcome. These then are some of the major reasons why some people support and some people oppose physician-assisted suicide. And what I now have the great pleasure of doing, to add depth and context to our discussion, it's my pleasure to introduce our two guest speakers. Our first guest speaker is Mrs. Cicely Hinson. Mrs. Hinson was born in Los Angeles, California, and raised in Pasadena. She earned her bachelor's degree in history from our own UCSB. She completed her master's degree in counseling and guidance from Cal Lutheran University. Cicely initially worked in education as a teacher and counselor for at-risk high school students for over 12 years. But for the past 10 years, Cicely moved into the healthcare field, most recently focusing on healthcare quality. She is the owner of Pathfinders Memorial Planning, where she works with families to help them through difficult decisions after a loved one dies, and also to facilitate difficult discussions on end-of-life choices. Cicely is married, has one daughter who lives in Oregon, and she is currently the Central Coast Field Organizer for Compassion and Choices. Ladies and gentlemen, please welcome to the stage Cicely Hinson.
Well, that's not intimidating. Thank you all so much. I'm so grateful to Dr. Hornstein for inviting me to speak to you today. I have a little slideshow, and I'll tell you all the specifics about SB 128, although he did an excellent job of describing its major components. I wanted to say that the reason I got involved in Compassion and Choices stems from my work with people who, after a loved one dies. And I realized that there are two things that happen. One, people aren't prepared to lose their loved one, and people don't believe they're ever going to die. And so a lot of the conflict, a lot of the grief and struggles that happen after someone dies are because these conversations didn't happen. And so you don't know, you wonder if you did the right thing, you're not sure what they really wanted after the death. And so it just, just to sort of follow up on today's Healthcare Decisions Day, advance directives are the way to go so that people know well in advance. And you can change them too. What you think is important today, what you would decide today for your health care, you may not feel the same way in 5 years or 10 years. But if your family knows, it's a true gift to give them to complete a healthcare directive. So I'm going to try this and see if it works. So I work for Compassion and Choices, and we are the oldest nonprofit working to improve care and expand choice at the end of life. We support, educate, and advocate. If you go to our website, www.compassionandchoices.org, you will see a whole section about advanced directives today in honor of National Healthcare Decisions Day. But one of the most important services we offer is end-of-life consultation, which is available throughout the country 24 hours a day, 7 days a week, and accessible through this 800 number. People who find themselves having questions for themselves or a loved one can always call this number and be hooked up to a trained professional. So as Dr. Hornstein mentioned, aid in dying is authorized in 5 states. Oregon and Washington passed their law, or it became authorized through a ballot initiative, and in Vermont it was through legislative action like we're trying to do with SB 128. Montana and New Mexico were through court decisions. So that means that those can be challenged at any time, and indeed they are challenged all the time. So it was introduced, I guess I could look down here, introduced January 20th by Senator Monning, Senators Lois Wolk and Assemblymember Susan Talamantes Eggman, And as you know, it would establish a law that's similar to the law that's been in effect in Oregon for almost 20 years. The Health Committee approved it, and the Appropriations Committee just approved it, and it is moving on. Judiciary, thank you. My cheering section here, thank you. My phone a friend. And it is going before the Appropriations by the end of the month or the first week in May. So, as mentioned, these are the basic components of the bill. You must be an adult, 18 years or older. You must have a terminal illness with no expectation of living beyond 6 months. Of course, we recognize that that is just a guess. I mean, doctors do not have a crystal ball, and there's no obligation for the patient to take the medication if they live past the 6 months prognosis. A qualified patient must make 2 oral requests to their physician, separated by at least 15 days, and then they must submit a written request which would be witnessed by 2 people. And 2 doctors must, a consulting doctor must confirm the primary care doctor's diagnosis. If either one of those doctors is concerned about their mental capacity, they could order a psych evaluation of that patient, and so that they could be judged competent to make this decision. The attending physician is required to discuss the full range of treatment options available. And to that end, we don't believe that medical aid in dying, as I like to call it, replaces palliative or hospice care. I feel like it's just one more option. In fact, very few people use this. In Oregon, last year there were about 120 people who applied for the prescription, and about 80 took it. Out of all the people that were ill in Oregon or died in Oregon, that's a very small percentage. And so, excuse me, we believe that those people who took it because their dying became unbearable. They didn't take it because they weren't because they were depressed or because of any other thing, but that they applied for and received the drug, and some of those didn't even feel the need to take it. They just felt great comfort having it in their possession. This participation would be voluntary. There is to be no coercion. That would be a felony if that were found to be so. They must be able to swallow the drug themselves, and the quantities involved, it's like 100 pills of barbiturates that you have to open the tablets, the capsules, and mix it in with orange juice. So it's quite a bit of drug. They have to be able to take it themselves. The doctor must explain to them the risks, benefit, expected outcome, including that it may not work, including warning them, like they tell you before every surgery and procedure that you go through, that you could die. Or in this case, that you might not die. Age or disability factors do not qualify alone. For example, a person who is elderly, just because they are elderly, does not qualify for this bill. A person who is disabled does not qualify because they're disabled. They must be terminally ill with a prognosis of 6 months or less, confirmed by another doctor. And again, no coercion. This is voluntary on the part of the patient, the physician, and I believe the pharmacists. No one is compelled to participate in this law. There's been a lot of concern about vulnerable populations, particularly the disabled, but we believe that there are sufficient safeguards in place. The person must repeatedly affirm their consent at each step. Active euthanasia is prohibited. it can't be taken in a public place. I don't know why that's a safeguard necessarily, but good to know. And, oh yes, no one can make a request for this on behalf of someone else, either by power of attorney or anything else. So you cannot include this in your advance directive and say, when I get to the point where I can't speak for myself, I want you to get me medical aid in dying. It doesn't work that way. The patient themselves must be able to ask for the drug and administer the drug themselves, and must be a fully competent mind. In fact, many people choose to have witnesses while they're taking the medication so that so the family has the comfort of knowing that it wasn't under coercion and everything else. And a really good movie to see this whole process is How to Die in Oregon, which is available on Netflix, if you wanted to see that. And I'm afraid if I go to my next slide, I don't know, but I do want to close on a personal statement by Brittany Menard, and some of you are familiar with her story. She sort of broke this wide open by coming forward about her struggle to try and get aid in dying in California, and so she moved to Oregon. What I'm going to show you is the testimony she recorded to be shown to the legislators in the Senate and the Assembly. And with that, I will close my presentation and my introduction. And I hope that's the next slide. We'll see.
My name is Brittany Menard. I am 29 years old and I am terminally ill. On New Year's Day 2014, to my great shock, I learned I had brain cancer. Despite the efforts of advanced medicine, my cancer is aggressive and currently without any cure. On New Year's Day, I was told I may have a few years to live with a grade 2 astrocytoma. This was a great shock to my family and I. Then post-op from a January craniotomy, my April MRI showed significant enhancement, indicative of a higher grade change. I was told I most likely had 6 months or so to live. My imaging was very indicative of a grade 4 glioblastoma based on MRI interpretations. A GBM4 is the most dangerous form of brain cancer, and my world fell apart. I moved to Oregon shortly after with my family from California because it is one of only 5 states that do authorize the patient a right to a choice with death with dignity. I am heartbroken that I had to leave behind my home, my community, and my friends in California. But I am dying, and I refuse to lose my dignity. I refuse to subject myself and my family to purposeless, prolonged pain and suffering at the hands of an incurable disease. Death with dignity laws authorize the medical practice of aid in dying. They give mentally competent, terminally ill adults the option to request life-ending medication that they can choose to ingest if their dying process becomes unbearable. The freedom of this patient right is choice. Besides Oregon, only 4 other states authorize the medical practice of aid in dying: Washington, Montana, Vermont, and New Mexico. Making aid in dying a crime creates undue hardships and suffering for many people who are terminally ill and suffering tremendously. It limits our options and deprives us of our ability to control how much pain and agony we endure before we pass. People have asked me whether I have explored the medical practice of palliative or terminal sedation. Some claim it is an equally gentle alternative for patients whose symptoms cannot be controlled. The procedure involves drugging the patient into a coma. Nutrition and fluids are then withheld until the person dies from disease or dehydration. No one can tell when that would happen. But each patient is different and deserves the autonomy and freedom to make this most personal choice for themselves. I can't imagine what that experience would be like. I may be minimally conscious, still suffering, and unable to move or speak. That terrifies me. Death with dignity is a much swifter and peaceful way to pass. Logic motivates me to choose this for myself instead. I refuse that procedure because I want to live fully until I die. The rest of my body is young, fit, and retaining fluid, so I would likely hang on for days or even weeks before I died. I don't want that. Also, palliative sedation usually requires hospitalization. I want to be sure my husband and mother are with me when I die. I want to leave this earth in my home, in the arms of my husband and my parents. I cannot change the fact that I am dying, but I am living my final days to the fullest, spending time with family, friends, and in the great outdoors. And I am preparing to experience the best possible death. Achieving some control over my passing is very important to me. Knowing that I can leave this life with dignity allows me to focus on living. It has provided me enormous peace of mind. The inevitability of death is universal. The widespread support and overwhelmingly positive response to my story represents our community is ready to have a new conversation about death. The decision about how I end my dying process should be up to me and my family under a doctor's care. How dare the government make decisions or limit options for terminally ill people like me? Unfortunately, California law prevented me from getting the end-of-life option I deserved. No one should have to leave their home and community for peace of mind, to escape suffering, and to plan for a gentle death. For the vast majority of people, that is not even a remote possibility because of the cost of moving, the inconvenience to family, and the time it takes to change residency status, find new doctors, confirm eligibility, and obtain medication. This must change. Every one of us will die. We should not have to suffer excruciating pain, shame, or a prolonged dying process. The laws in California and 45 other states must change to prevent prolonged, involuntary suffering for all terminally ill Americans. As elected officials, you have the power to make this happen. Please take action. Every terminally ill American deserves the choice to die with dignity. Let the movement begin here, now. Access to this choice lies in your hands. Freedom from prolonged pain and suffering is a most basic human right. Please make death with dignity an American healthcare choice. Thank you.
Can we also give a hand to Cicely Henson for an excellent presentation? It's now also my pleasure to introduce our second guest speaker, Dr. William Rajala. Dr. Rajala was born in Minnesota and had the good sense to grow up in Santa Barbara. Somebody hissed. Is that? He received his undergraduate degree in biology, also from UC Santa Barbara, and received his medical degree from Northwestern University in Chicago. He completed his residency in internal medicine at the Fresno Valley Medical Center, and he is double board certified in internal medicine and hospice and palliative medicine. He is currently the medical director of assisted home hospice and palliative care in Ventura County. On a personal note, Willie is married and has 3 teenagers. In addition, he has another teenager exchange student because one can simply not have enough teenagers in your house. Hence, he's here talking about physician-assisted death. Ignore it. Bad. I'm sorry. That wasn't fair. Willie also plays the cornet in the Ventura British Brass Band. Ladies and gentlemen, my good friend, Dr. Willie Rajla.
So my dad was the one who made the decision to move from Minnesota to Santa Barbara. He was trying to decide between Victorville and Santa Barbara. And he was convinced he was going to go to Victorville because it was hot, because Minnesota was not hot. So he said, let's go to Victorville. But then he went to Santa Barbara, was at the Pepper Tree restaurant, and heard some people, overheard them say, gosh, it's raining. It's just like a nice winter's day here. And my dad said, if this is winter, I'm moving here. So that's what brought, so I'm always thankful for those two ladies at the Pepper Tree restaurant for getting me to Santa Barbara instead of Victorville. And indeed, I do have a German foreign exchange student for the whole year because, yes, 3 teenagers in high school, you needed 4. We just needed 4 for that. Well, I would like to thank you for coming. This is a tough topic. I mean, it's brought out a lot of people, and I appreciate everybody coming to kind of get the discussion rolling here. And I appreciate Dr. Hornstein's comment that this isn't necessarily a debate, it's a discussion to get you start thinking about physician-assisted suicide, but much more so advanced care directives. And like he said, 30% of the people in the United States have an advanced healthcare directive. That's kind of poor. We've got 70% of people that can express what their desires are when they're still aware of it, so that then families don't have to suffer through, what should I do, what should I not do, I don't know what to do. So please, if we had, how many people do we have here? Probably 200 some? If we had 200 some advanced healthcare directives out there, that would be our best option. But I encourage you this week, track down your advanced healthcare directive and start thinking about that. Because that's the big take-home message almost for me tonight. Yeah, you can get it with your physician. You can go to Compassion and Choices. So there are places you can get it, but make that step. Don't just sort of think about it. Make that step to get the piece of paper to get you going. So I'm here to discuss a slightly different take on this discussion here. And I wanted to talk a little bit about the medical society and their viewpoints towards physician-assisted suicide. American Medical Association, about 2/3 of the way down, it says physician-assisted suicide is fundamentally incompatible with the physician's role as a healer. It would be difficult or impossible to control, but I think the idea of incompatible with the role of a healer 2,000 years ago plus is when the Hippocratic Oath was started out. Interestingly, Hippocratic Oath does not say the phrase, do no harm. But there are various other things that talk about how we're called as physicians to take care of the sick, be available, not to abandon their patients, and fundamentally to not purposefully cause harm. So I think that's an important part. California Medical Association, 7 times in the last many years, has also said, we don't think physician-assisted suicide is a good thing. Like how this matches? It was just accidental, but I kind of like the touch. My socks match too, so I'm feeling good. Feeling good. So a couple things with the California Medical Association, they talked about trying to decide, is somebody truly competent? Do they understand what they're doing? And that's tough sometimes. It's really difficult. The second point of being, to make this decision, is life no longer worth living? And again, to make that decision, because the Senate bill says that the two doctors have to help make that decision with them. The patient can say, I don't think I'm worth living, but the physicians have to go along with that concept. And that's difficult for physicians who are not personally involved with those patients on a day-to-day basis, who know them well. Yes, attending physicians who have seen them, patients for years and years and years, can have a good understanding. However, in one study looking at the Oregon law, most attending physicians have been their attending physician for 8 to 12 weeks. I don't know how they're going to understand longitudinally what their psychological situation is if they've only known them for, a few weeks. Terminally ill patients, that's a hard one, because we're kind of crummy at deciding and understanding what is a terminally illness, what is a terminal illness, and what's 6 months or not. National Hospice and Palliative Care Organization also say that we have a lot of skills and a lot of ability to manage all those distressing things that happen at the end of life. Now, why do people commit suicide? Not physician-assisted suicide, but suicide. Huge percentage, 90%, are committing suicide because they're depressed or have some kind of psychological illness. Is it different for those desiring physician-assisted suicide? And to some degree, yes, but not that much different. A lot of people have depression, and we talked about that already. Dr. Hornstein actually basically gave my entire talk before I even started. So I should have just said, just remember exactly what Dr. Hornstein said, and then we'll be set. So, but the big fear of being a burden, losing control, those are huge issues, huge psychological issues that are not just, it's just a psychological problem. No, those are very personal and debilitating things at times. Uncontrolled pain, as we've heard, that isn't that common a cause for why people want physician-assisted suicide. So we know that they all have a large psychological component. Even the pain, physical pain does, because there's spiritual pain, spiritual suffering, psychological, all that kind of stuff. Now, are there alternatives to physician-assisted suicide? And I believe that there are several that we can do. Palliative care, as Dr. Hornstein mentioned, is talking about helping to manage symptoms of suffering and end-of-life care. Hospice, I believe, also provides compassionate care and gives choices on an everyday basis. A terminal illness, not expected to live more than 6 months if their disease progresses as they think. There are 2 doctors that need to certify that, their attending physician and then the hospice doctor, or another doctor can do that. There are other specific guidelines for other types of illnesses that we don't need to go into. But on hospice, probably 15 to 20% of people live more than 6 months. And some of them live for a year or 2. If people do not continue to decline, then we use the term they graduate off of hospice. Medicare says they have to be discharged from hospice if you're not showing a decline. So there are patients who live much more than 6 months. We just are not that great at predicting how long somebody's going to live. If somebody's on hospice, that's not necessarily a terrible problem, because if they continue to decline, they can just continue to receive hospice care. If, however, you're going to say this person is going to die from a physician-assisted suicide, but their 6-month prognosis is actually much more than that, you can't say, oops, we made a mistake. That patient is dead, okay? So there isn't really anything coming back. We didn't make the diagnosis correctly. You're done with that. And that's a problem that I can see. Talked about some of the similarities with the bill that's out there. Two physicians do need to evaluate the patient. No psychological requirement is needed. If the attending physician or the consulting physician says, yes, I think there's a big psychological problem, then they can refer to a psychologist or a psychiatrist. But sometimes depression or other psychological problems are fairly subtle. Attending physicians, primary care doctors are not psychological specialists. We try our best. I'm an internal medicine doctor, but I am not a psychological specialist, psychiatrist. Interestingly, there was a study out that 6% of psychiatrists feel very comfortable that with one evaluation, one visit with a patient, can they, with certainty, understand their psychological situation. 6% of psychiatrists say that with one visit, and that's all that's required. So that's a little concerning to me that a psychiatrist who's a specialist is not feeling fully confident with one visit, but that's all that's required with the bill. A consulting physician doesn't have to have any specialty. They could technically be an internal medicine, family practice. They could be a dermatologist. They could be a radiologist. It says a consulting physician. That's from my understanding of the bill. Physician does not need to be present. Now, a couple of concerning things. The medicine can take 15 minutes to have its effect, but up to 48 hours they have found that sometimes it takes. What happens to those patients when they're just lying there? I don't know, but that is pain, and that could be pain and suffering that is miserable, that if that patient says, you know, I'm just going to be alone, I choose not to have anybody around me, that could be a miserable end of death. So it's not a compassionate, comfortable death guaranteed at all. 16% failure rate in one of the studies. What do you do with those people? Do you have to give them, do you refill the medication? Do you have to give them a shot of something? I don't know what you do. In the study that there were 120 people who died in Oregon, and 120 patients, I believe, were given the medication. 80 people decided to take the medication. 40 people did not. What happened to that lethal dose of medicine that's just kind of floating around in the community? And if it gets in the hands of a child who thinks it's something, what happens to the physician if they say, well, I wrote the prescription, but somebody else got a hold of it, am I responsible for that? So those are some things that I have to think about at least. Suicide, whether it's patient-directed or physician-assisted, can cause huge emotional issues with family long-term. There's huge amounts of guilt, and that can be a big problem that, well, the patient has passed away, but the family deals with this for a huge amount of time. Doing hospice care, amazing things happen in those last days to weeks of life. I see it all the time. Family members come together who've been bickering and complaining. They come together. They have a resolution of issues. They learn to appreciate small things that we take for granted, smiles on a face. The family just gets drawn together. Not always, but a lot of times they can. There is a sense of closure when people are understanding what this process is, what's happening. And adult children say, it is tough to take care of your dying mother and father. There is no doubt about it. But there is something amazing and profound that can happen when you do that. It is hard work. It is hard work. I don't want to belittle that at all, but it can be really rewarding and change those family members as well. So not always, but people can miss out on some of those amazing experiences because they decide that I'm going to end my life sooner. How do we in hospice deal with these kind of issues? It is not myself as the doctor writing prescriptions to manage pain medication. Yeah, sure, I do that some. But it's a lot of counseling because we know that most of the things that happen at the end of life can be a huge psychological burden. So we deal with that in psychological ways. We treat for depression. We do counseling, spiritual counseling, social workers, psychologists, psychiatrists, whoever's needed to try to help deal with this. We have nurses who just love these people in amazing ways. So it really is a team effort and can be satisfying for everybody involved. So I feel that we have the knowledge and the ability to care for patients at the end of life. Do we succeed 100% of the time? No. I confess that we don't do a perfect job every time. Can we do better? Yes. Do we need to do better? Yes. Would we benefit from more funding? Yes. Would we benefit from more resources available? Yes. Would we do better with more patient education and education in the community? Definitely, all those things. But it seems that we should put our efforts towards those issues because I feel that they do provide a good quality of life at the end of life. And a statement that might be a little irritating to people, but I look at it as, I don't think you see a psychiatrist ever say that. Would they? But since we know that physician-assisted suicide is almost always a psychological issue with loss of dignity, feeling that they're a burden. I mean, those are heavy burdens, but they are psychological issues. We don't typically treat a psychological issue with a non-psychological treatment. Thank you.
Thank you very much, Dr. Rajla. I think we have time for a few question and answers before we get to our end of discussion rant, where we have our individual panelists have a time to actually conclude. I've got a couple here, and again, please feel free to take a shot at this. What happens if a terminally ill patient can no longer swallow oral medications? As you just said, they have to take 100 different pills. They can't for a variety of reasons. Maybe they have obstruction from a cancer in their esophagus or in their stomach, or they're vomiting, or let's say they have a neuromuscular problem. How do you actually overcome that, and is that right? If we're creating this new right and then create this barrier saying, well, you have this right, but you got to do it this way, but not other ways, how do you overcome that barrier? Do you want to take a shot at that?
Okay.
Not putting you on the spot, but
No.
I don't want to take a shot at that, actually, right?
No. The intent of the law is that a person would be able to self-administer. So if they were incapable of swallowing, then it would stand to reason that they would no longer be able to access the law. In terms of, is that fair? I would say, nothing's fair. I mean, but at the same time, the law is very specific and very narrowly defined for the purpose of, to answer the concerns about the slippery slope and to answer the concerns about people being taken advantage of who are vulnerable. So what would happen is that, hopefully the end of this death with dignity would be in conjunction with hospice and palliative care, and not exclusively either or. That's why we do not think that it's an either or option. Now, if someone is in institutional hospice care, it's a little more problematic, but if someone is in home hospice care, I think it's a little simpler. But in terms of also the drugs being, the unused drugs being a danger to the people around them, it would be subject to the same regulations as any hospice medications that would be available to the patient. So I think that we're talking about the same concern and care for the patient and for society and for the families involved as hospice and palliative care, and I do not see it as an opposition.
So a question, there was a question about what to do with people who are terminally ill and can't swallow, and I don't know if that was actually directed also towards hospice patients, because that's also an issue. What do you do with people who have terrible pain and can't swallow? So we have a variety of medications that could be given underneath the tongue, on the skin, given through IVs, so that's not an issue for hospice. The question of what happens with the lethal dose of medications if they're not taken. In hospice, there are clear directions as to what to do, how to manage the medications that are in the home, whether they're put in a lockbox, whether they're put on top of the refrigerator, putting somewhere where children can't get to them. So there's a lot of education regarding that. I don't think there is with the law, because they aren't necessarily thinking that somebody is not going to take the medication. So they aren't going to say, you know, if you decide not to take this medication, these are the things you should do with the medication so that they does not get into hands that are a problem.
And I just want to add that there are multiple amendments that are being proposed to this bill, raising the concerns that people like the doctor here are raising. And so I think that you can rest assured that a lot of these things are being addressed at the legislative level, and they're not something that I am particularly aware of, but that is what the legislative process is all about, is to bring forth a bill and have people weigh in on what's missing from the bill, and you know, how can we strengthen the safeguards and that kind of thing. So.
SB 128 requires death certificates to list. So if somebody actually has a terminal illness and takes the medication and dies from the medication, in the current state of the law that's being proposed, SB 128, it says death certificates is to list the cause of death as the underlying terminal illness rather than physician-assisted suicide. And the question I have is why? Because let's face it, if a terminally ill patient gets into a car accident, dies from the accident, while they still have a terminal illness, we put the cause of death both legally and morally as the car accident. And yet they are dying of an overdose of Seconal, and yet the bill says no, they are to be put the terminal illness and not physician-assisted suicide. Can you explain why that is, and if that's something that should also be amended in this law?
First of all, any discussion about that, I'm not an attorney, and but that is probably something that is in discussion in Sacramento. But the thought is that if people have access to the law and they do it according to the law, that their life insurance will then continue to pay out. If someone dies in a car accident, there's no question that they died in an accident, whereas if you die of suicide, then that may invalidate some insurance policies. So that's what I think the thought is behind that.
Yeah, I think that that's probably a reasonable answer. I just should tell you that as a physician who assigned hundreds of death certificates, I'm both legally and morally obligated to put the cause of death, regardless of benefits of insurance or what other people tell me to do. So I think that's a big problem, that in fact, we can't ask our doctors to lie and to misrepresent what actually is going on, even if it's well-intentioned. So I think that's something that needs to be looked at, and that was the point of the question. But now picking on Dr. Rajala. Dr. Rajala, many people, especially the homeless and the poor who have terminal illness and are dying, have no real home or family with which to help them cope with end-of-life problems. How can they receive adequate hospice and palliative care?
Well, it does become more difficult because you need to have people around to help you do those things. Now, people who are poor, don't have any money, don't have any insurance, what the goal then would be to get on Medicare, Medicaid, Medi-Cal, because that's available, then you can provide hospice services in a skilled nursing facility. Medi-Cal will pay for nursing home care, so that can be taken care of. There are for-profit hospices and not-for-profit hospices, so depending upon which type they are, you can still get care even if you have no money whatsoever. So there are ways to get care for people who are poor, who don't have family around. It is more difficult, but it can be done.
Can I add something
Please,
about
absolutely.
that? Yeah, about, you know, the intent of the bill is, of course, not to exclude the family at all. In fact, in Oregon, what has happened is there's been an increase in discussions among family members and an increase in palliative, access to palliative and hospice care. It just opens up the conversation, having that law established in Oregon, and I would hope for the same here. And so the whole idea of having a patient kind of go rogue and say, I'm going to end it all and take it, you know, despite my family, is probably a rare occurrence. And as you saw in Brittany's case, very much a family decision with physician advice.
A couple more questions. Is the treatment of terminal sedation, does everybody know what terminal sedation is? Okay, terminal sedation is a legal, medically approved procedure where the goal is to take someone with intractable pain, think of the worst pain in the world, and you simply treat the pain to the place where they actually go into a coma. The treatment itself leads to a coma, but the intent is to treat the pain. Now, once you put somebody into a coma or a terminal sedation, of course, they will die, okay, because they can't wake up and they can't eat and they can't move. But the intent is not to cause death, but is to aggressively treat pain. And that is something, Dr. Rajala, have you done that?
I have done that.
Right.
It's pretty rare that it has to be done. I've done it 2 times in the last almost 5 years.
Right, and to those of us who are in palliative care, I also have done it. But the question is the treatment using terminal sedation ever appropriate medically to treat mental anguish or emotional suffering or feeling like a burden or a loss of bodily control? In other words, should terminal sedation be used for indications other than severe physical suffering? Dr. Rajala?
If you're wondering how that question connects with physician-assisted suicide, what we're trying to do is look at, are there options to helping people pass through?
So a comment up in the front is, which I think is a fair comment, sir, but I think the question is, if you look at the data coming out of Oregon of the people who actually use physician-assisted suicide to kill themselves, 70% do it because of mental anguish, emotional suffering, feeling a burden, loss of bodily control. They do not do it, less than 10%, because of severe pain. So the question is, in Oregon, we treat people with physician-assisted suicide for these psychological and emotional and spiritual issues. Do we do the same with terminal sedation?
And I would not use terminal sedation to treat a psychological type problem. I would use psychological care to help deal with that. I would use terminal sedation for physical distress that can't be controlled. Again, it's quite rare that we ever have to do that because we have a variety of medications to help manage pain, anxiety, manage shortness of breath, nausea. We have a wide variety of medications to help people get those symptoms under control.
I would say that what is confusing about that statement is that it implies that a mentally distressed person would be able to access the law, and they would not, unless they were terminally ill with 6 months or less to live. And I don't see why the law would preclude anyone from treating them psychologically as well as accessing the law. I don't see that as incompatible either.
I don't think it would preclude them, but patients are not required to be evaluated if they have mental anguish that is not actual depression. The attending physician and the consulting physician don't necessarily have to consult a psychiatrist if they don't want to. They don't see that that's a big enough issue.
So clearly, this evening, we have touched on obviously a very emotionally charged issue with strong feelings of individuals saying this is individual rights and compassion versus wondering if this is the right way to handle end-of-life care. And I think we could go on for a long time, but I think suffice it to say this is the beginning of an argument and a beginning of a conversation that I certainly hope we take outside of this building. However, as is our custom in these series, it's time to give both our guest speakers a final opportunity to share their concluding thoughts. And Dr. Rajala, you was second on the first, so would you
I get
please
the first shot? Okay.
give us the first shot?
So I feel that we have a lot of options available in order to help care for people at the end of life. I know there's the desire for choice. We don't give unlimited choice to everybody for everything. If somebody comes to the doctor's office, if they want an antibiotic for a viral infection, they probably shouldn't get it. If somebody wants surgery for their gallbladder and because they have abdominal pain, but if it's not indicated, then you probably wouldn't give them the choice. So we don't give choice to everybody at all situations, even though the desire is to provide choice. I think there are plenty of choices with what we have now, with hospice and palliative care and psychological services, mental health. We can do much better, but I don't think we're to the point where we give up and just say, no, I don't think your life is worth living any longer.
As we conclude our program, to continue this passion and advocacy for people at the end of life is admirable. But at the moment, could we let our speakers simply have a couple of minutes to have some final remarks? So Dr. Rajala.
So I just feel we have things that we can do. And it's difficult for me to help somebody decide what their life, how much of their life is worth living, how much how do I state it exactly? Am I to judge as to the quality of somebody's life? And I have to, if I'm an attending physician who signs this, I'm saying that giving you this medication, I agree that I think your life is not worth prolonging. That's difficult for me to make that judgment.
Cicely?
Okay, couple things. One is I do understand the predicament that the doctor's in. However, I think I'm just going to relate a personal story. I'm going through it right now with my mother, who's in kidney failure, went into the hospital, tried to do dialysis, didn't like it, and asked to have the shunt removed, and she's just going to allow herself to die naturally that way. That was her decision. The doctor didn't support it, but she was adamant. She said, "This is what I want." So I think that it's not the doctor who has to decide respectfully whether or not you feel the quality of life is adequate, but it's the patient that decides. And so I've chosen to respect my mother's decision and support her in the time she has left. I also wanted to bring up that in Oregon, it should be noted that out of 25 people who apply for this law, only 24 are denied. So there is some, in other words, the doctors, the primary care physicians, they are the ones who determine whether or not someone really is truly eligible. A majority are rejected out of hand. And that still leaves about it's rising, but about 122 patients that actually do qualify and about 2/3 that actually end up taking the medication. If you're interested in seeing this progress through the legislature, I also want you to know that if it is going to the appropriations. If it should fail in the appropriations, it will be a dead bill. But we are looking at the possibility and probability of doing a ballot initiative in 2016. And so we have information out on the table, a petition and letters to the Appropriations Committee that you can either fill in and we'll mail, or you can take home and mail to all the committee members. And we'll be out there answering any questions you may have. What we believe is that this will expand the choices at the end of life, and not, in addition to what's offered by palliative and hospice care, so that the patient has more choices. Thank you.
Ladies and gentlemen, before we close, I just want to reiterate my hope for tonight's program, which was, as I mentioned earlier, twofold. If you came here and you favor legalization of physician-assisted suicide, I hope after this program you can now at least understand why the person sitting next to you has several real concerns and reservations. And if you came here and you opposed physician-assisted suicide, I hope you can also more fully appreciate the struggles and barriers which terminally ill patients often have when they face end-of-life issue. And with all of our passion and with all of our concern and with all of our sense of doing the right thing, I think all of us should leave here tonight, as I mentioned at the beginning, as winners, because we have just spent 1.5 hours in civil discussion figuring out ways to improve and enhance the care, more or less civil discussion. No, really, come on, it's civil discussion. In ways to improve and enhance the care we provide to all patients in the state of California, and that's awesome. And for that, I think each and every one of you should pat yourself on the back for showing great restraint and great intellectual honesty. And I also feel that when you all get home, you should give a big hug and a big kiss to your kids, to your spouse, to your in-laws, and to anyone else who you feel is near and dear to you. And then after you've shown the love, would you please sit down and fill out your advance directive? Honestly, come on, it's about time. It's also time that we thank our two very brave guest speakers, Ms. Cicely Winson and Dr. Willie Rajala. I would also like to close by thanking our host for this entire ethics series, the Community Memorial Health System. I very much look forward to seeing you again in the fall. For tonight, thank you so much for coming, and have a great night.